All right. Hi, everyone. Thank you so much for joining us. This is Bethany O'Connor from Health Policy Plus, and I'm here to welcome you to today's presentation titled Having It and Spending It Too, Unblocking Public Finances to Achieve HIV Epidemic Control. We have a fabulous broadcast for you today, and we'll begin with just a few announcements. First of all, we all know this is just a very unprecedented time, and all of these web conferencing platforms are getting a lot of traffic, which is why we actually had to change platforms at the last minute to GoToMeeting. We had a very successful dry run on Friday, but we just ask for your patience if for any reason there are some glitches today. Just rest assured we will address the problem very quickly and move along with the presentation, but just flagging that in advance just in case we encounter any bumps. Secondly, this broadcast is being recorded and we'll make the link and slide deck available shortly after the broadcast. Regarding Q&A, we'd love to hear from you and we welcome your questions. Please submit your questions via the chat box at absolutely any time. It's on the right-hand side of your screen, and if your little console is collapsed, it's kind of like the cartoon bubble icon with the 3 dots in it above the pencil icon. So you can submit those questions at any time in the chat box. And finally, and this is most important, we ask that if you're not speaking, that you please mute yourself to keep the line nice and quiet while others are talking. And that concludes the little announcements portion. So now I will hand it over to my colleague, Jorge Ugaz. Jorge, take it away when you're ready.
Thank you very much, Bethany. Good morning. My name is Jorge Ugaz. I work here at Palladium under the Health Policy Plus project as a Senior Technical Advisor on Health Economics and Finance. I want to start by thanking all of you for taking the time to join us today in this webinar. We are aware that these are very challenging days, so we thank you for being with us today, engaging in this hopefully interesting and fruitful discussion about some of the recent work that HP Plus have been doing on PFM with a specific focus on HIV and AIDS. We have with us 3 great speakers from the HP Plus project. We have Francis Zelika, Stephen Mushiri, and Lyubov Teplitskaya, who will talk about some of the exciting PFM work that we have been carrying out in Nigeria, in Kenya, and Indonesia, respectively. As we know, one of the key focus areas for the Health Policy Plus project relates to increasing domestic resources for health in low and middle income countries, putting in place sustainable financing mechanisms so that they can ultimately make progress towards universal health coverage goals. Under the USAID-led PEPFAR SFI initiative, we have also been building an evidence base to advocate for increased government allocations to health, sensitizing key players about the importance of DRM, adopting sustainable health financing mechanisms in the long term, developing investment cases across all health areas. And yet, as of today, we're witnessing a few countries still falling short in terms of obtaining enough domestic resources that will allow them to reach their key health objectives. We're seeing that in some countries, the gap seems to be so large that these objectives sometimes look simply out of reach. We know that countries need to spend more funds on health, and yet we also know that spending more is not going to be enough. For the last few years, we have been discussing about the need to better prioritize health during budget negotiations, to establish budgetary earmarks for health. But as we're going to hear today, in most cases, approved funds sometimes are not being released, are not being executed, and sometimes are not being spent or not being spent efficiently. For HIV, for example, now the COP20 minimum requirements is asking countries to increase their resources expended, and finding innovative ways to finance HIV programs is a critical, but sometimes also elusive task that we have to accomplish. And this is where PFM strategies can play a strategic role, bringing up spending efficiency gains, increasing poor budget execution rates, mobilizing domestic resources, etc. So this diagram, the one that you can see on your screen now, somehow resembles the cascade of care for HIV treatment, but it tries to simplify somehow the different budgeting stages to show how and where PFM can be a powerful tool to address different challenges. In this case, for example, between the first two columns, we see that the budget for health spending increases from year zero to year one, let's say after a successful DRM campaign. And while that is, of course, good news, focusing on the columns on the right is equally, if not more important. And I'm going to take a couple of seconds to remind people in the audience to please mute themselves when possible. Thank you. So sometimes funds for health that have been approved are never transferred or released to their respective entities. And that's what we're showing between columns 1 and 2. And the potential reason for this could include low prioritization, lack of capacity within the funding mechanisms, poor accountability, weak political capital, among others. For the next phase of the budget cycle between columns 2 and 3, what we see is that sometimes only a portion of the funds that are transferred or released are actually expended. And this is actually what one of the new minimum requirements refers to. Even if we hold the amount of funds under column 2 constant, the question is, what can we do for governments to increase the amount of funds that are actually being expended? This is a serious issue since, as we know, public funds allocated to health that remain unspent are typically returned. And potential reasons for this fall between columns 2 and 3, it can include poor planning, low budget credibility, inaccurate costing, unrealistic budgets, and sometimes even also over-centralization of the release process. And the challenges of this over-centralization is actually at the core of some of the type of work that we have been carrying out in HP Plus in Indonesia and Kenya, as will be illustrated by my colleagues. And finally, between columns 3 and 4, we look at how efficiently the money is being spent. So we know that countries need more and better health spending. As they mobilize more funds for health, many countries urgently need to improve on how they're using those funds. The World Health Report from 2010 estimated that between 20 and 40% of all health resources are wasted. A recent publication by the Global Financing Facility sort of summarized all the causes for such inefficiencies as 1, spending on the wrong things, 2, spending in the wrong settings, and 3, just spending badly. At HP Plus, we think that a strong PFM has the power to, 1, to address specific bottlenecks and obstacles that restrict the proper and timely release of funds, 2, to improve the absorption rates and actual expending of those funds, and 3, promote the efficient use of resources. But it's also important to keep in mind that while PFM can be improved within the health sector itself, it's also imperative the active participation and commitment across all different levels of governments, as we know. So we're going to see that we also think that the situation of each country, of course, is always unique, but as we're going to see today, some common actions emerge. And I personally think that the lessons learned from our experiences across these 3 countries can be applied to other contexts, to other budgets and programs across all different health areas. So I'm going to stop here. Frances Ilika, she's our next speaker from the HP Plus office in Nigeria, and she will take us through the work that she and her team undertaken in Nigeria. So Frances, I pass on the microphone to you.
Thank you very much, Jorge, for the introduction. So I'll be sharing the experience of HP Plus Nigeria in domestic resource mobilization for health through a PFM lens. Next, please. So I'll be focusing on the Nigerian HP Plus objectives, and then we would like to understand the PFM cycle, the strategies and the challenges, and then we'll move on to show a case study of a successful example from one of the states we support. So HP Plus Nigeria follows a sector-wide approach where we provide support to governments in health financing and governance reforms aimed at mobilizing domestic resources for HIV/AIDS, TB, and RMNCH, but with a sector-wide approach to actually improve the way that these resources are allocated, the way they are released and expended, and as well to ensure efficiency in spending. Next, please. Next, please. So a little background, as we all know, Nigeria contributes to a high burden of HIV/AIDS globally. We could see that a very high percentage of Nigerians, 1.5% of Nigerians have HIV/AIDS. And over the years, we could see that the government is not rising up to the challenge of providing adequate resources for funding HIV/AIDS. We could see from the graph that over 70% of the funding is from donors, with about 27% from the government. And if we look at the graph on the right, we can actually see that over the years, the funding gap increases. So not only is government funding inadequate, but there is a huge segment of the required interventions that we need to control HIV/AIDS that is unfunded in the country. Next, please. So for us to be able to understand some of these challenges, we want to reflect very briefly on the budget allocation cycle, looking at the PFM cycle. So this is a typical cycle where the government will develop the policy trust, and then the Ministry of Economic Planning will send a circular to the MDAs, who will set their priorities, send in their budgets, and then they will subsequently need to defend these budgets at the Ministry of Finance and the House of Assembly, and then it goes back to the governor before it becomes a final state budget. Next, please. On the budget release cycle, we could actually see that the MDAs will need to request for these funds to be released. So if the MDAs do not do that, then this cycle cannot start. So they will need to request for these funds to be released. It goes to the state governor, and from there it proceeds to the Ministry of Finance, who will have to ration based on available resources, and it goes to the Accountant General before the MDAs release funds. Now, it's very important to know that along the cycle for both allocation and release, there could be obstacles at every stage of the cycle. Also, there could be opportunities for influencing increased allocation and releases to HIV/AIDS. So everything depends on the actions of the health sector actors and how they're able to involve other people. Next, please. So let's reflect a little bit on the PFM challenges. So the PFM challenges that actually inhibit resources being mobilized for HIV/AIDS cuts across the whole budget planning process, budget execution, as well as utilization and how efficiently these resources are being used. So we could see that one of the key issues is low budget credibility, or sometimes unrealistic budgets. For instance, in many of the states, you could actually see that the budgets allocated for the state is about 5 times the revenue that the state has ever been able to raise at any given time. So what this means is that the best budget execution that the state can actually get is about 20%. And this means that the health sector will need to compete for these scarce resources with other sectors who are usually better positioned to ask for these resources than the health sector. Another key issue is that prioritization is often political and is not program-based. So whoever has the ears of the governor is the one that is likely to get funding. And of course, the health sector is not able to leverage on this. Usually because HIV/AIDS and TB are not adequately prioritized because it is believed that donors are funding these sectors. Now, for us to be able to demonstrate that there are gaps and that the government needs to step up to this challenge, we need evidence. And most of the times, this evidence is not usually available. Moving on to budget execution issues. Most times it's often political, and the decision is made at the central level. So to a large extent, the governor of the state decides where money goes to. Now, because the state actors have a suboptimal understanding of the PFM process, as well as the political economy of their state, they are not able to engage adequately. So most of the times they do not write memos. When they write memos, the memos are often not convincing. And even when they send out the memos, they do not follow up and they do not engage the other actors that have the power to draw resources to the health sector. Oftentimes, even when these funds are released, they are often not being spent efficiently. Most of the times they are channeled through the wrong methods. For instance, in one of the states, the bulk of the funding went to the agency that was responsible for community mobilization, as against the agency that was responsible for purchasing of drugs and commodities and testing kits that would go to the facility level. This resulted in a lot of outreaches and mobilization done, but not adequate test kits and drugs for people at the facility level, and this was a big cause of inefficiency. And then finally, there are poor accountability mechanisms to track, to make sure that these resources are actually spent on the right things. Next, please. Some of the strategies that we've been able to put in place is to work with the government to make sure that we're moving from input-based to program-based budgeting, linking results, linking inputs to results, helping the MDAs and the agencies to plan and actually develop interventions that will actually lead to results, budget for it on time, even before the budget cycle starts, so that they are able to actually budget for the right things and make sure it's prioritized. We're also strengthening multi-sectoral approach by making sure the health sector is speaking to other sectors that have the power to draw resources to the health sector across the PFM cycle, from the ministries of economic planning, ministries of finance, the parliamentarians, the office of the governor, and all the other people who have the power to draw money to this health sector. They are being engaged by the health sector. We're also building the capacity of the health actors on PFM and understanding of the political economy so that they can engage adequately. And then, of course, we're improving accountability mechanisms by stimulating the oversight role of the legislators, as well as getting the CSOs to be involved in accountability. So in all, we are actually working with the state actors to make sure that there is an appropriate mix of financing mechanisms for HIV/AIDS through public financing, prepayment mechanisms through health insurance, external financing, as well as innovative financing. But more importantly, to make sure there is a good synergy among these financing mechanisms. So basically, we're moving away from poor government funding to effective domestic resource mobilization from the government, moving away from out-of-pocket expenditures to health insurance, and moving away from predominant donor funding to integration of HIV/AIDS services into health insurance. Next, please. So we'll share a case study from Lagos, which we got from interventions of USAID through the Health Finance and HP Plus project over the years. So we worked with the Lagos state actors who had this PFM challenges that we had highlighted earlier to put in place the necessary measures to address these issues through formulating the right policies, developing the right interventions and proper planning, intelligence gathering to be able to demonstrate to the policymakers that there are still huge gaps in HIV funding and the impact that this could have on the health sector, as well as on the economy and also on the political environment of the states. We also help them to put in place institutional arrangements, making sure that they are leveraging across the different sectors and speaking to people from other sectors who have the money to draw, who have the power to draw resources to the health sector. And then, of course, we made sure that the accountability mechanisms are in place to make sure that the resources are spent adequately. Next, please. Now we were able to achieve a lot of results as a result of this intervention. We were able to support them to make sure they mobilize adequate resources for the state health insurance scheme. And then we worked with the states to make sure that HIV services were included into the state health insurance scheme benefit package, as this will be a stable, predictable, and sustainable financing for HIV/AIDS in the state. In addition to that, we worked with them through the PFM cycle to make sure that adequate resources were allocated to HIV/AIDS. As we could see from the graph on the right, we could see the allocations to HIV/AIDS increase over the years. 2016 was the date that the intervention started, and over 2017 and 2018, there was increased allocation. But it didn't just stop at allocation. They were actually able to get these resources released for the first time in over 4 years. And we could see that they had increases in allocation over the years. We're also supporting them to make sure that these releases are actually put to best use and they actually reach the facility level. They're able to prioritize, make sure that the commodities, the testing, the treatment, and everything that they need is available and at the appropriate amounts. Next, please. So this is the, in conclusion, we just want to highlight that to have an effective DRM process, we need to support and build capacity of actors at the state level, at the national level, and in other settings on public financial management and political economy so that they will be able to engage adequately to draw resources to HIV/AIDS. Multi-sectoral collaboration is going to be very key in increasing health prioritization and in overcoming these PFM obstacles. In addition to that, we need to make sure that there are good accountability mechanisms to to ensure that when we mobilize these resources, they actually lead to real-time improvements in HIV/AIDS programming at the country level and at the state level. And then finally, perhaps the most sustainable way of making sure that there is stable and predictable financing for HIV/AIDS is by making sure that they are included in key government interventions like state health insurance schemes and other interventions. So this is the little we wanted to share with you on the work that we've been doing in domestic resource mobilization in Nigeria. Thank you.
Okay, thank you very much, Francis. Let's move on to our next presentation. Before just I mentioned to all attendees, if you have any question, I ask you to please hold on to your question until the end, as we will have a discussion at the end of our session today. Now we're moving to our colleague, Stephen Mushiri from the HP Plus office in Kenya. So Stephen, I pass on the microphone to you now.
Thank you, Jorge. We want to share with you what Kenya is doing and in using PFM to be able to improve financing both for health and HIV/AIDS. Next, please. That will be the outline of my presentation. I will look at what we are doing to support PFM in Kenya across the sectors, how national county governments are investing in health and HIV/AIDS, the whole issue of absorption and allocative efficiency on health and HIV/AIDS, and finally some lessons learned, challenges, and the way forward. Next, please. Next, please. In terms of background, just like Nigeria, 62% of total HIV/AIDS funding is from external sources. And what is a bit worrying is that if you look at funding for ARV, 90% of the funding comes through PEPFAR and Global Fund. Only 10% is funded through government. Donor support is declining, and hence the need for more DRM. Good thing is that we have got a growing economy and a big middle class that is coming up, and this offers an opportunity for Kenya to be able to test how private sector can be able to come in terms of financing and delivery of ARV services in Kenya. And finally, is that PFM offers an opportunity for advocacy of DRM and how those funds are being used. Next, please. If you look at how the two governments are investing in health over the last 7 years, you see very big growth from 5.5% as a percent of total government budget to 9%. This is 3% below the target for 2021-22. Counties are also investing, largely on health. The good thing is that the PFM Act of 2012 invest money for going to the counties. So those funds, whether spent or not spent, they cannot be returned back to the national treasury. So the money that we worry about is funding that is allocated to the national government, which if you don't spend by the end of the financial year, that funds get returned back to the national treasury. But overall, I think you see a very good improvement in the way both governments are investing in health. Next, please. Now we look at how national government is prioritizing funding for ARV. In the year 2013-14, the sector was involved, health sector was involved with the counties, and we had 2 years when we are not funding for ARVs. Since 2015-16, with the support of HP Plus, we were able to advocate for creation of the budget line item for ARVs, which was restored with an allocation of $20 million. Since then, that amount has been growing to that $9 million in next financial year. And if that funding is retained, the contribution of government to ARVs will be increased from 10% to 25%, which is a very big improvement in terms of ensuring that we sustain the HIV/ARV epidemic. Next, please. However, even as government are increasing funding for ARVs, if you look at absorption from 15-16, it has been going down to the lowest of 12% in the year 2017-18. And the factors that contribute to that absorption is basically the lower tender prices, delays in procurement. Sometimes bidders go to court, and this slows down the procurement process. In the year 18-19, we see a big jump, basically because government were paying the bills that were accrued from the previous financial year. So that 14% because government was trying to mop up those pending bills. Next, please. Now, looking at the counties and how they invest in health and HIV/AIDS, if you look at the counties from the time that were created in the year 13-14, they have doubled their allocation, which is commendable. But if you look at investment on HIV/AIDS, basically has not, doubled the way it has doubled for the overall allocation from $2 million to $4 million. But to us, what is important is not that counties allocate $4 million, is the fact that counties are now appreciating their role in financing HIV/AIDS, because with the onset of the revolution, counties perceived HIV to be a national government function, and they didn't want to allocate any funding. So the fact that HP Plus was able to intervene through dialogue between national government and county government, and counties are now prioritizing HIV/AIDS, to me, that is positive, and we hope that going forward, they'll be able to earmark funding for HIV/AIDS. But as I said before, ARVS are procured centrally, so this funding is to support other non-ARVS activities relating to HIV. Next, please. Next, please. Now, HP Plus Kenya, our approach to improve absorption rate and allocative efficiency, we do several things. One is that we generate evidence. We produce what we call county health accounts. We produce public expenditure analysis. All these are supposed to inform both national government and county government on how they are spending and how they are allocating funding within their private areas. We strengthen the use of that data for decision making, and we engage county assembly and national assembly in terms of letting them know how HIV/AIDS is being funded and where they need to come in to support additional funding for HIV. We do budget advocacy across the continuum from national government, county government, targeting key stakeholders who influence how allocations are set up. And we also do what we call training and mentoring in program-based budgeting, trying to link budgets to priorities, using data to develop the annual work plans, which we monitor annually on how counties are performing. And finally, in the counties that we are supporting, we prepare action plans which are targeted to increase efficiency on health spending. Next, please. Some few results I want to share with you. One is that if you look at the counties that we are supporting, there's increase in growth rate of health budget allocation in HP Plus counties. You see the blue ones where the counties increase their budget from 12% to 14%, while the other counties which are non-HP, the budgets were reducing from 17% to 13%. And this is because we were there to share evidence, do a bit of advocacy, train people on how to link budgets to expenditure, and this is contributed to improved allocations in the counties where we work in. Next, please. The second result area is the increase in absorption rate across HP Plus focus counties. You see the counties that we work in, we had increase in absorption from 79% to 88%, whereas overall, counties were reducing absorption from 82% to 79%. And basically it's because of the things we have said, trying to tie, building capacity, being there to monitor the expenditure on a quarterly basis, doing a bit of, mentorship with the team on the ground, and more important, participating in the sector working groups that informs how counties will be able to improve on absorption. Next, please. The other result area is that if you look at how counties perform in terms of overall budget absorption, and these are the 7 counties where we work in, you see there's improvement across the board when compared to average, and basically it's because we're able to be there to support them, mentor them, and track the expenditures, and also have a quarterly meeting with them to be able to address those bottlenecks that may be hindering the absorption, and that this contributed to the overall absorption across the seven HP Plus focus counties when compared to the other counties. Next, please. Now, in conclusion, I think a few lessons learned. One is that counties continue to have weaker capacity on planning and budgeting, and this is an area that we are discussing with the Minister of Health on how we can be able to continue strengthening their capacity across the board, including setting up a very strong planning unit to be able to spearhead the planning functions at county level. Bottlenecks in funding flows within the county from national government, counties, and eventually to the spending unit. There's an issue that in Kenya, all funds have to go through the county revenue account before they are disbursed to the spending facilities, and this sometimes, hinders the flow of funds. So we are discussing on how can we be able to, get the funding to the facilities as opposed to getting through the county revenue account. So we are supporting the counties to create an act that will be able to have them bypass the county revenue fund. Weak coordination of stakeholders for efficient delivery of health services. I think there's a lot of coordination issues that we need to work on among the stakeholders in Kenya on how we can be able to improve efficiency. And finally is vertical disease approach to DRM, creating a bit of confusion. Today you are in the county discussing about DRM for HIV/AIDS. The next day you are discussing about family planning. The next day someone else discussing about malaria. And this messaging is going to the same team. You are advocating the same team. And sometimes you wonder, why don't we get a coordinated approach that will ensure that when we go to the counties, we go look at the need, the gaps, and then we advocate for comprehensive approach as opposed to verticalizing our approach in terms of support to DRM. In terms of way forward, is, as I said, strengthening the county planning unit to undertake planning, budgeting, coordination of the health sector without external support, and transitioning HIV/AIDS funding within the medium-term expenditure framework. I think we have already supported the Council of Governors to come up with the structure. We are waiting for the buy-in, and once they get a buy-in, they'll be able to hire staff in the 7 counties. For HP Plus, will be able to build capacity on planning and budgeting so that those officers will be able to play an active role in the MTF to inform budgeting going forward. And 2 is harmonizing or planning tools to allow for uploading of PBB, program-based budgeting, compliant budget into IFMIS. IFMIS is a tracking tool. This is where the money is spent. PBB is planning tool. So we are trying to see how do we link the two to ensure that when you do a PBB, it's able to get into the IFMIS, and IFMIS, we use the IFMIS to be able to track those expenditures, and we track those expenditures by sub-program and interventions. So that's what Kenya is doing in terms of using PFM to be able to be self-reliant both at national level and county level, and to be able to mobilize funding to support health and HIV. Thank you. If there are any clarifications, I'll be happy to clarify.
Thank you very much, Stephen. Very interesting. Now we're going to move to our third presentation on Indonesia. Lyubov, we pass on the microphone to you.
Thank you, Jorge. Hi, everyone. Today I'll be discussing some of HP Plus's work to support the government of Indonesia and PFM in light of decentralization and the introduction of minimum service standards for basic health prevention and promotion services. Next slide. More progress is needed to reach 90-90-90 in Indonesia. The government plans to rapidly scale up access to HIV services to achieve its targets under the new ART acceleration plan, such that 40% of people living with HIV are on ART by the end of 2020 and 90% on ART by 2027. This entails adding 130,000 people over the course of 2020, which requires new approaches to address service delivery and financing barriers. Next slide, please. A significant amount of HIV funding, 74%, is spent by the government of Indonesia. However, these funds can be spent more efficiently. Strategic purchasing through Indonesia's national health insurance can secure a more sustainable source of financing for the HIV response. In addition, local government resource allocations currently do not prioritize HIV and remain small at 5% of total HIV funding. This funding will need to increase to meet minimum service standards for HIV and to meet the goals outlined in the new ART acceleration plan. Next slide. Here, I'd like to present some background on Indonesia, where decentralization was first implemented in 1998 to allow local government more responsiveness to local needs and interests. Decentralization was thought to provide fairer allocation of resources between central and local government and among local governments, as well as to enhance the quality of services, given the local government's closeness with people and their needs. Shortly after decentralization, the Minimum Service Standards, or SPM, were introduced as a way to address varying quality of service provision across Indonesia. However, because no formal accountability mechanism was implemented to hold local governments accountable, the central government was still responsible for meeting SPM requirements, with local governments just serving as implementers of the program. Between 2004 and 2016, more detailed technical guidance was issued to districts. However, issues concerning accountability remained. Most recently, in 2019, the new regulation has shifted the onus on local governments to meet 100% of their SPM targets, which are now set through a formalized process. The Ministry of Home Affairs now has the authority to reward or issue sanctions for local governments that do not meet SPM. In this sense, although the SPM was originally intended to function as a quality assurance or standards model, in practice, it functions as a system to manage local government's performance with targets for service coverage. Next slide, please. HP+'s support focuses on the SPM for health, which are comprised of basic health services, the primary health care level, which, as you can see here, include 7 indicators for services in the life cycle, from pregnancy, delivery, and newborn health services, to services for the elderly, as well as services for diabetes, mental health, hypertension, tuberculosis, and HIV. For HIV, local governments are responsible for HIV prevention, detection, including outreach, and linkage to facilities for ART treatment. Next slide, please. Several implementation challenges remain. The SPM regulation does not address financial, human resource, and technical capacity constraints between districts, which continue to persist. The onus now falls on local government to plan and budget for SPM, as well as execute high-quality service delivery. These responsibilities include developing appropriate SPM service targets based on the population in need, planning for appropriate human resources and supplies to meet SPM in the absence of any comprehensive technical guidance that specifies numbers of human resources and supplies needed. Local governments also need to estimate their budget to implement SPM, but have minimal technical capacity to do so. The tools provided by the Ministry of Health are complex, and no costing studies have been conducted to guide accurate SPM budget estimation. Lastly, local governments are responsible for monitoring SPM implementation at the facility level and reporting on SPM achievement. These monitoring and reporting activities may require hiring additional staff. Other implementation challenges persist at the central and local government levels. The central government faces serious challenges in communicating technical guidance to 543 subnational governments. Local governments also face challenges in coordinating service delivery at public and private facilities and with civil society organizations to meet 100% of their SPM targets. Often, networked health facilities, especially private facilities, do not report service utilization to each primary healthcare center. Lastly, local governments set targets based on the number of individuals in need of a service. However, individuals may seek care in health facilities outside their district municipality area for quality or other reasons. This would challenge a local government's ability to fully meet its SPM target. Next slide, please. HP+ is supporting central and local government, as well as civil society, to strengthen PFM processes for HIV and for health-related SPM more broadly. First, we are conducting costing studies to improve local government's planning and budgeting tools to meet minimum service standards. And we're developing electronic learning modules to aid districts in using these tools. We're also supporting the central and local government in assessing how the Special Allocation Fund can be used to better prioritize investment in SPM for HIV and other health services. The DOC is the only subnational funding source for which we can steer prioritization of specific line items for SPM, since other local government funding occurs through block grant mechanisms. Similarly, we're improving CSO capacity to submit accurate HIV budget requests to local governments for HIV funding. HP Plus is also supporting the Ministry of Health's abilities to communicate SPM and other PFM technical guidance to districts. One approach has been to communicate important guidelines at annual health meetings that are attended by hundreds of district officials through materials such as the infographic seen here on the right. Currently, the government uses separate platforms to monitor local governments' SPM plans, budgets, and actual reporting on SPM performance. HP Plus is providing support to improve the interoperability of these monitoring and evaluation platforms. Next slide, please. Sector-wide, planning and target setting are conducted before any budgeting occurs, with planning occurring from January to May and budgeting occurring from June to October. These separate tracks are problematic and have led to an inflexible, input-focused budgeting approach with volume focused on total targets. There is a lack of policy-based budgeting to meet SPM, which is more forward-thinking and aligns budgeting to goals or outcomes in the future. To use HIV as an example, the input-based budgeting approach does not differentiate budget for different testing strategies for each population. Per the guidance in the table on the right, you can see that outreach for at-risk patients is grouped together for all populations, and the cost of transportation is the same for all, for example, for pregnant women and for female sex workers. But we know that key populations are more difficult to reach, and as such, transportation costs will differ. Using a policy-based budgeting approach would account for these differences and produce budgets that are more accurate. Next slide, please. As I mentioned earlier, we are also working to strengthen civil society's understanding of the budget cycle, as well as their ability to develop budgets that reflect HIV program goals. This technical assistance will strengthen civil society's ability to develop funding requests to local government that reflect differences in costs by intervention, activity, as well as differences in costs to reach key populations. Next slide, please. I'll conclude with some recommendations for Indonesia. Although the mandate for local governments to meet 100% of their SPM targets is still nascent, local governments have been implementing minimum service standards since 2002, and we have not seen sufficient progress in reducing health service inequities across Indonesia. At this stage, it's important for the government to review the real purpose of SPM. Is it to ensure a certain minimum level of quality for all Indonesian citizens? This seems to be the original goal of SPM. However, in practice, SPM is functioning as a performance management system for the local government. This is mainly because SPM indicators are target-based, reflecting inputs and coverage, as opposed to stronger measures of quality, such as outputs and outcomes. This is relevant for HIV. Indicators on number tested are not indicative of meeting a certain quality standard for HIV services. One measure of HIV service quality could be percentage of patients identified that are placed on ART and retained during the year. Under the current SPM HIV indicator, all populations at risk, including pregnant women, tuberculosis patients, and key populations, must be tested each year, which is unrealistic and at odds with a targeted key population testing strategy. For SPM to function optimally as a performance management system, incentives must be implemented and tailored for both strong performers and weak performers, and the Ministry of Home Affairs must begin to use its new power to issue rewards and sanctions. Lastly, SPM socialization to citizens is also needed in order for the public to be more aware of minimum service standards and hold their local governments accountable. Thank you. Happy to take questions.
That's great. Thank you very much, Luop. Very interesting. I think now we have some time for Q&A. I think we may have some questions that have already been sent. If you have some questions that you would like to pose to some of our speakers, you can please send them in the box to Bethany. Bethany, do you want to lead this Q&A section?
Yes, absolutely. Thank you so much for that plug to submit questions. We are open, and sometimes it just takes a moment for folks to type out their questions because those presentations were so engaging. But I'll start with the question that was submitted in advance of the presentation via email. First of all, what consistently works to ensure allocated amounts are released for the HIV program? Is it a question of convincing local staff that these funds are truly needed and are not replaced by national or donor support? Or is it about the overall health impact of the spending? And we'll need the panelists to unmute themselves, and whoever wants to answer can go for it.
Hello. Okay, so I'll try to answer this from the Nigerian perspective. So I would say it's both. So first of all, convincing the health actors that there is a need to actually request for funding. For instance, when we started working in many of the states, we actually discovered that they hadn't been writing memo requests for fund releases because they had become so dependent on donor funding, one. Number two, times in the past when they had requested for funding, it didn't lead to any results. So they gave up after a while. So we had to actually engage them and convince them that, you know, maybe you need to do things differently this time to get a different result. So we had to go through that process of convincing the health actors themselves. And then moving beyond the health actors, you also have to convince the decision makers, people from the finance ministries, as well as the office of the governor, to say that you need to allocate and release more funding to HIV/AIDS. And for you to be able to do that, you need to generate evidence, like I illustrated during the presentation, that even though there is donor funding, there's still a wide gap. And then perhaps more importantly, the impact of this on health, on the economy, on their political aspirations and all of that. So you have to demonstrate this across these different levels to get them to actually believe that we need to get more government funding for HIV/AIDS. On the other hand, I think to a large extent, a lot of them know what the health impacts are. And of course, they believe that for you to get more results, to actually have more impact on the health sector, you need to spend more money on HIV/AIDS. So I'll say it's a bit of both, but maybe perhaps more of the first one, to say that everybody needs to understand. And to do that, you need evidence, generate evidence to show that you know, what is being done is not adequate and we need to do more.
Thank you, Francis.
Let me jump here.
Go ahead.
I was going to say that in the Kenyan context, there are two things. One is that if you want the funding allocated to be released, you have to prepare a detailed work plan that stipulates what you are doing, the targets that you want to achieve, and more important is when you need that money. Because treasuries will release that money on monthly and quarterly basis. If they don't have a very good cash projection from your program, it's unlikely that treasury will release that funding. So preparing that annual work plan with the target and a very detailed cash flow, monthly and quarterly, is important. Two is very good relationship between health sector and the county treasury or treasuries, so that treasuries knows when you are going down, so they're able to prioritize the cash release coming monthly or quarterly. So that linkage between the sector and national treasury is important on continuous basis to be able to inform the treasury on when health sector is likely to go down in terms of funding.
Thank you so much, Mushiri and Francis, for those responses. We appreciate it. I'm going to go to our next question here from Sarah. Could Nigeria talk about some specific accountability mechanism they're using?
Okay, thank you very much for that question. So in the presentation, I had mentioned two different broad areas of accountability mechanisms. So one of them is accountability from the legislators. So the legislators have statutory functions of appropriation, legislation, oversight, and accountability. So we're leveraging on their oversight and accountability functions to say they need to provide oversight to the way that health spending is being spent. They need to provide oversight to make sure that there is availability of health services. So this cuts across HIV/AIDS as well as the other health intervention areas. For instance, sometimes they go on visits to facilities to find out if people are getting access to the services that they need to get. They're also able to provide oversight on the way that the health funding, which they have appropriated, is being spent. So they have oversight on the budget itself, and they also have oversight on implementation of activities. So that is one of the areas that we're focusing on to make sure that legislators are able to use this oversight to improve the efficiency of spending on HIV and AIDS. Now, the second area that we're working on with regards to accountability is the civil society organizations called the CSOs. So they are there in the communities. And an example of this is when we did the user fee assessment to find out how much people are paying fees at the facility level, despite the fact that these services are meant to be free of charge. So when we discovered that people were actually paying a lot, over 1,500 Naira per visit. So we, one of the things is to get the CSOs involved to actually monitor and track what is happening at the facility level, because they are closer to the people at the community levels. So if they are able to monitor and track, and then we're also able to provide linkages between the CSOs and the legislators so that they can report what they have found, as well as between the CSOs and the decision makers at the state level, the ministries of health and all of that. Now, there is a mechanism that brings everybody together called the DRM Technical Working Group, or in some states, Health Financing Technical Working Group, that involves people from the finance ministries, the legislators, the CSOs, people from the health sectors, from the Office of the Governor. And at these technical working group meetings, people give reports of what is happening across the whole PFM cycle, from allocation to releases to the way the money is spent. And then CSOs also get the opportunity to report what is happening at the community levels. So I would say these are the two key broad areas that we're focusing on with regards to accountability.
Great. Thank you so much, Frances. Our next question is from Carlin Mann. She says, thank you, panelists, for this presentation. I would like for all panelists to provide brief information of what the teams are doing to ensure sustainability of such efforts presented here. For example, in Kenya, there were 2 years where the ARV budget line item was removed. So what is being done to ensure that there is continued focus on domestic financing and absorption of funds for health and HIV/AIDS, especially as countries are faced with other priority areas and health outbreaks such as COVID-19?
Let me try to respond to Karin's question on sustainability and how to ensure that we sustain what we are doing. Two things. First and foremost is that all the work that we are doing relating to program-based budgeting, we are doing jointly with Kenya School of Government, and we are building capacity there such that if HP Plus exit, that institution will be able to take up that curriculum and run with it and continue training county teams on the PBB. We are also building capacity in 2 institutions, one Strathmore School of University and University of Nairobi, to be able to support government in evidence generation, doing some physical space analysis, doing a bit of costing, so that going forward, those 2 institutions will be responsible in advising government on where they need to invest, and they can be able to be doing those reporting for them. And finally, is that as part of USC agenda, we are also trying to get the team that is championing that agenda to appreciate the role of HIV/AIDS, how it is funded, so that as they mobilize funding from National Treasury to support USC, there will be more funding allocated to HIV/AIDS. If you look at the figures which are shared for next financial year, you see a very big jump. That was because of that interface between HP Plus and that panel that is driving that agenda, And because of that, we're able to get them to understand that although this animal is heavily funded by the donor funding is declining, and hence the need for you to be able to get some funding that you have for UAC to come and support UAC in an effort to support the journey to safe lands.
Yeah, thank you very much. I'd like to add from the Nigerian perspective that some of the things that we're doing is institutional strengthening in the areas of institutional strengthening and capacity building. So we've worked with the states to have a technical working group that is multi-sectoral in nature, being drawn from the different areas, and capacities are being built to make sure that they are able to continue to do this work. In addition to that, the technical working group has a secretariat located within the Ministry of Health, the Ministry of Department of Planning, Research and Statistics, called the Health Financing Unit. So we're doing a lot of work building the capacity of the Health Financing Unit to generate evidence, to use this evidence for decision making, to plan adequately and support the MDAs in actually requesting for funds and to continue to do the work that they have to do. But as I had mentioned during the presentation, perhaps more importantly, we're working to make sure that HIV, AIDS, and TB and other key health sector interventions are integrated into the state health insurance schemes. Now, the state health insurance schemes are the government directive, the big health financing reform that is happening, and it's going to be the new mechanism for health system support across all the states in Nigeria. Laws, legal frameworks have been passed, and they've been put in the laws, and finances have been made available through the laws. So we're making sure that HIV/AIDS are captured in these state health insurance schemes to make sure that every year through the budget cycle they get sustained funding to be able to continue to do this. We think that perhaps this is the most sustainable way of making sure that HIV/AIDS is provided for. I think another thing we're also doing is working with the legislators. We have what we call a legislative network for universal health coverage, and this has actually taken foundation in Nigeria and it's growing. So the legislators are now playing a bigger role in making sure that adequate funding is made available for the health sector.
Thanks, Carlin. And in Indonesia, we are developing district capacity to effectively use the budgeting and planning tools for minimum service standards. Previously, the MOH had released these tools and there was no guidance provided. And so there's been pretty weak implementation at the district level. And so now we are making sure that we're developing capacity of districts using the electronic learning modules, and also making sure that we are strengthening district capacity to build realistic budgets that reflect what's actually needed to meet 100% of the minimum service standards. And then secondly, the Special Allocation Fund, or the DAC in Indonesia, reflects specific line items for SPM as well as other health services. So we're looking to support the Ministry of Home Affairs and the Ministry of Health to discern which districts are actually prioritizing SPM and how can we steer districts to request specific line items for SPM in order to make sure that the local governments are actually prioritizing services that are the 12 services, basic health promotion and prevention services.
Thank you so much, Lubov, and all our panelists. And thank you, everyone, for submitting these fabulous questions and making this a really fruitful discussion today. We are 2 minutes away from our wrapping time. So I also just wanted to put in a plug. Please, everybody, mark your calendars on Wednesday. We'll be presenting at 9 a.m. Another webinar, Eliminating Tuberculosis Through Sustainable Financing Approaches. And hope you can join us for that. We'll be on GoToMeeting as well. And I want to turn this back over to any panelists or anybody who has anything else they wanted to share in conclusion before we wrap.
I think for me is to mention that sometimes the reason why you find low absorption is because there's too much external funding. So people tend to spread donor funding first because they're easy to access, and because of that, they go to the government funding when it's too late in the financial year, and because of that, they don't spend. So I think we need to manage the two to ensure that when they are spending, the program, the expenditure on both government and donor as opposed to only focusing on one to start with.
Thank you, Misheri. We really appreciate you and all the panelists. Thank you everyone so much for tuning in, and hope you have a fabulous rest of your day. That concludes today's broadcast, and everybody take care.
Thank you.
Thank you, Bethany. Thanks, everybody.
Thank you. Thank you.